last presentation, but it's something which is a different option for treating infectious keratitis. So we have a recorded video of Rarhad Hafeji here. Doro, you want to say something?
Yeah, I was going to share the screen for Farhad because he's made a presentation.
Please.
Okay, do that. Yeah.
Hello, this is Rarhad Hafeji from the ELSA Institute in Zurich, Switzerland, and the topic of this presentation is photoactivated chromophore PAC cross-linking for infectious keratitis. These are my financial interests. Now, looking at the background, please remember that whenever you speak about cross-linking or PAC cross-linking, in fact, the two methods only differ by name. The underlying mechanisms are always happening, which are not only biomechanical stiffening, but also steric hindrance, so increased resistance against digestion, and killing of anything that lives on the cornea and within the cornea by these two different mechanisms: DNA, RNA intercalation, and oxidative stress. Excuse me. Another big important background element is the fact that we have several components that are essential for successful cross-linking, which is light, riboflavin, but also oxygen. And as you know, oxygen plays a central role for cross-linking in keratoconus, and relative lack of oxygen is the main driver why acceleration of cross-linking for keratoconus cannot just happen deliberately, but is limited at a certain moment in time. We were the first to show this back in 2014, oxygen as an essential component. This is cross-linking for keratoconus. Interestingly, PAC cross-linking for infectious keratitis is much more independent of oxygen, and you can accelerate even down to 3 minutes, 2.5 minutes even, without substantial loss of efficacy. Again, we published on this 7 years ago. The very first clinical data were obtained by our group and published back in 2008 in cornea. This was a case series of 5 cases that were unresponsive to typical antimicrobial therapy. And a few years later, we decided to coin a term and we called the new method PAC cross-linking, and PAC stands for photoactivated chromophore. A chromophore could be riboflavin, but also others. So we didn't, even 13 years ago, we didn't call the method photoactivated riboflavin because we knew at that time already that other chromophores, like, for example, rose bengal, might enter the game. What we tried soon was to accelerate the treatment based on our laboratory findings, but as you can see here, we always stayed at the 5.4 joule that came with the original Dresden protocol for keratoconus. So we kept the same total energy, but accelerated the settings from 30 minutes down to 3 minutes, and we compared cross-linking plus antibiotics against antibiotics alone in this larger study on bacterial keratitis, and what we found was a significant acceleration to healing. So the epithelium closed much faster when you performed additional cross-linking. Even in cases like this one here, the average ulcer size was a little more than 3 millimeters. At the same time, we have been running a prospective randomized multicenter trial where we compared the effect of antimicrobial therapy alone against PAC cross-linking alone, and here we implemented several countries and we used accelerated and high fluence PAC cross-linking. So not only accelerated, but as you can see in the upper right corner, the intensity was increased by 30% from 5.4 to 7.2 joule. And here we had a very interesting result that will be published now in the next weeks, which is in Press with Eye and Vision. We saw no difference in days to healing and in the success rate, whether you use medication alone or PAC cross-linking alone. In other words, no significant difference. And this is a very, very interesting and encouraging finding. What are the next steps? First of all, we need to increase access, which means we need to realize that everything I've shown you until now is only true for a certain part of the world's population, those who have access to modern ophthalmology, because we typically perform cross-linking in an operating room under sterile conditions. But how many percent of the world population really have access to this? It is only a few scarce percent. What happens to everybody else? Let's have a look at India, a huge subcontinent with remote large areas that are underserved. And we know that, especially in infectious keratitis, you have to treat as early as possible. And this means serve the remote areas, increase the coverage, bring the technology to the people and not the people to the technology. In other words, democratize access to cross-linking. That's another topic I've been working on for the last 7 years. And our solution is bringing cross-linking to the slit lamp, especially for puck cross-linking where the eye is already infectious and you don't have any increased risk by performing a puck cross-linking procedure office-based, as you can see here. And this has been working now for 1.5 years in clinical practice, and we are very excited about this possibility to increase access for all people. Besides increasing access, we have to increase efficacy, and what we have found is very interesting in terms of lab results. As you can see, if you increase the total intensity from the original 5.4 joule from the Dresden protocol to 15 joule in bacteria, let's say, you increase the efficacy to almost 100%, and it is similar for fungi. And this explains why you read again and again, even in the current literature, about large trials that were not successful. My own group, we published 8 years ago an unsuccessful study where we compared additional puck cross-linking to medication alone. But as you can see, we worked in huge ulcers, almost 8 millimeters, and we didn't see any difference in time to healing in these almost impending perforation cases. And very recently, a similar result was published by an Indian group for deep fungal keratitis. And what we have learned in the meantime in the past 8 years is that you have to increase efficacy. And as you can see, this large trial was performed with the 20-year-old settings of 5.4 joule. And look what happens if you go to 14 or 15 joule in large fungal ulcerations, as you can see here, before and after. This is 14.4 joule. So in other words, we have to adapt our technology too. I love to take the example of cataract surgery. For a clear lens extraction, you use very different technical settings than if you were to face a white, mature cataract. You increase your power settings on your phaco device. Same thing here. So we have to work on increasing efficacy by increasing the fluence. One last step, a very brief outlook into the future. Besides riboflavin, there is rose bengal. And if you look at the absorption spectra, these two chromophores do not compete on the cornea. They need very different excitations. Riboflavin uses 365 in the UVA range, whereas rose bengal uses green light at 522 nanometers. So the question is, why can't we combine these two, for example, in fungal keratitis or in acanthamoeba? And we have started doing this in a pilot study with a prototype. So these are two entirely different devices, and we have treated the same patient in the same session with riboflavin puck cross-linking first and then with rose bengal puck cross-linking. And the results in this first patient are promising, and we will continue our study here. So in conclusion, puck cross-linking overcomes antimicrobial resistance, which is a huge and increasing topic all over the world. It also helps you treating mixed cases where you have a diagnostic dilemma if you don't know whether your case is only bacterial or only fungal or even mixed, because you address unspecifically, you kill everything that is around. Remember you have to massively increase the fluence to increase efficacy. We have improved the access using slit lamp-based cross-linking. We improved the efficacy using high fluence, and the future will probably also see combinations of chromophores. So very exciting outlook for the future. Please follow me on Instagram for further updates.